welcome to our first edition of In Conversations With. And this is just looking to try and promote research that's going on in care homes and give people the opportunity to hear more about it and ask questions and hopefully have a conversation about this topic. So today we're lucky to be joined by Susan Shenkin, Shona MacDonald and Bernie McInally, and we're going to have a short presentation from Susie, and then we will be putting some questions to the speakers. But first of all, I just wanted to take the three speakers in turn and just ask if you could introduce yourself. So Susie, over to you.
Yeah, hi there, I'm Susan Shenkin. I'm a Professor of Healthcare for Older People at the University of Edinburgh and a consultant geriatrician at NHS Lothian. So I have a clinical role and an academic role.
Thank you. And Shona, are you happy to introduce yourself?
Yeah, hi, I'm Shona MacDonald. I'm the home manager of a small home in Edinburgh. I'm a nurse and I've worked in social care for about 15 years now.
Brilliant, thank you. And Bernie?
Hi, I'm Bernie McInally. I'm a clinical studies officer with ENRICH and the NDN. My history is 25 years as a community psychiatric nurse in older adult mental health teams. So I've had a lot of experience within care homes.
Brilliant, thank you. I should probably add, as I'm chairing it, that I'm Rosie and I lead the Rich Voices as part of ENRICH Scotland, which is our equivalent of patient and public involvement group. So I'm going to hand to Susie first to tell us a bit about the project today, and I will mute myself just so it doesn't echo.
Thanks so much, Rosie, and really happy to be able to explain this exciting project to you all today. We have a little bit of visuals to support this for the people who are online, but if you're listening back, I will explain everything as well at the same time. So while the visuals are being brought up, I will let you know that the data sharing partnership is what we've called this research project that was funded by the Chief Scientist's Office. We're very grateful to their funding for this really important project. And it's a research project that aims to really understand how we can bring data together between healthcare and social care. It's a partnership between the University of Edinburgh and DataLoch, which sits within the Data Driven Innovation Partnership Programme of the University of Edinburgh at the Usher Building in near the Royal Infirmary in Little France, and also that's the trusted research environment in the university. And the most important partnership that we formed was between the university, DataLoch, and with our care home partners. And we're really grateful to Elder Homes, to Lucy House, and to Braeburn Home, of which Shona is representing today, to partnership with us for this project. The partnership involves two main projects, which I'll very briefly explain, which we called Loch Dali, which I'm grateful to Franz Gruber for this acronym, the Lothian Care Home Data Linkage Project, and the Data Sharing Partnership. And these are both got slightly different mechanisms for sharing the data. Loch Dali is using data within DataLoch itself, whereas the Data Sharing Partnership, we did ask the individuals whose data we were sharing for their permission to do that. So I'll explain those briefly just now. But just to explain first that you may think that all of our data can be seen by everybody, but that's not the case. If you're seeking health or social care interactions, your data is the information about you is held in may not be seen by everybody at the same time. Hospital records, general practice records, care home records, and the prescriptions that you have are held in separate systems that don't easily talk to each other. So what we were trying to do in this partnership project was to safely and securely bring information together from these different places to try to improve the understanding about the individual who sits in the middle, the person who is living or staying in a care home. And hopefully in the future, by understanding this for research, we'll be able to use this to improve care for these individuals in the future. And this has never been tried to be done in Scotland before. So it was a groundbreaking project from that regard. So the Loch Dali project was a project that sat within DataLoch in University and NHS Lothian. Within DataLoch itself, there's a mechanism for identifying care homes. It's called the UPRN, or the Unique Property Reference Number. And we used this way of trying to say, can we identify our 3 partner care homes in the NHS Lothian data set? Can we use that information that sits in NHS Lothian, that includes people's hospital information, people's GP information, and people's prescribing information, and can we put that together and show that to the care homes and say, does this look like a summary of your residents? So that was the first project, identifying the care home in data law, making a summary of that information from what's held in the NHS at the moment in the trusted research environment, and showing it back to the care homes. And then the second project, the data sharing partnership project, has been a bit more of a challenge to set up through ethics and governance processes, because what we were trying to do for the first ever time in Scotland was to take information about individuals who live or visit care homes, because Lucy House is a respite care home, so people don't live there long term, they just visit for shorter periods, and take that individual level data, share it into data law, match it up with their healthcare data, and then show that summary back to the care homes and say, how do these 2 sources of information match up? Does the information that's collected in the care home look the same as the information that's collected in your formal healthcare record, in your GP record, in your hospital record? Are the medications that are prescribed in your NHS systems, if that's what the care home think that you're taking, how well do these 2 things agree? So taking the data from the care home and sharing that with data law, linking that with healthcare data and showing that back in a summary fashion to the care home. And as I say, the legal and governance process around that was that we had an agreement between the care home and data law, and then the individual care homes asked the residents if they were happy for us to do that. So that's what we've been working through, and I think we're getting the final agreement signed almost as we speak, so hopefully we'll have some real live data for you very soon. So just to show you what a dashboard might look like, you can see a very short summary here of the sort of thing. This is using very made-up data, this isn't real information about a resident, but perhaps if you were to see a dashboard for a care home of the data that was identified when you found the care home using this unique property reference number, and you said, what's held in NHS Lothian about my residents? A summary might say that your care home has 100 beds, 120 residents have been through there in the last year, 20 people might have died. It might tell you the number of people you've had per whole-time equivalent staff member, and it might be able to give you some information about their age, their length of stay in the home, their level of frailty, how many medicines they take, how many men and women there are, the contacts they've had with healthcare, like their general practitioner, what kinds of prescriptions they've had, what diagnoses they have, for example, dementia or delirium, how many times they've attended hospital. So what we've been doing this partnership project was then to develop this dummy data and then to talk to people like Shona and say, is this helpful? Is this a sort of thing that would be useful to you? What different information could be used here? And we're trying to develop a very iterative process to explain, to work out what we should show, what we should include in a dashboard like this. And then we'll work together to try and make this really much more useful for people going forward. So this was our first idea of what something might look like. And similarly for the data sharing partnership, we thought a dashboard might include things like in showing what variables, what information we have in the care home and what's in the hospital data or in the general practice data. How well do they overlap? If we think that this care home has 50 people who identify as women, is that what it says in the care home data? If we think that people's body mass index or weight is something in their healthcare data, is it similar in their care home data? If we've got a diagnosis of dementia in their healthcare data, is it there in their care home data? So we're looking at agreement between the 2 sites and then seeing what information is in one site or in the other. So that's very broadly the sorts of things that we might be able to show in those kinds of, using this kind of information, but this is really just the first step on a journey. This is our first chance to try and share this information, to try and understand what's there, have a better picture of that, and then together to work out exactly what will be useful for the care homes and how we can move towards together to make this better for the future, for both research and for care.
Thank you very much, Susie. And you said there that you would think, putting to Shona, is this useful? So I am going to hand over to you, Shona, and say, is this useful? How have you found this work?
This has been really interesting to try and get our heads round. Whenever I've spoken to any of the families, they just assume that all of these talk to each other and we all have the same information, but we really don't. Which is really frustrating. But when we've been looking at the dashboard and looking at the types of things that we have to report to with the care inspectorate or anybody like that, it's actually quite helpful to be able to say, oh, we've had this many urine infections, we've had this many of this, that, or the next thing. And just to be able to have that rather than having to trawl through sometimes lots and lots of data, especially if you don't have a system that automatically logs those things for you, which a lot of homes still don't. And even it's only as good as what we put in it. But if we've got lots of people putting in the same information, hopefully it would be pretty accurate. So yeah, it's been really exciting to try and figure out what information and what things are actually useful to find out about, and just sort of looking at it and pulling it apart and putting it back together as well.
Absolutely, thank you so much. And I'll go to you, Bernie, and ask you to tell us a bit more about how your role as a clinical studies officer aligns with projects like this.
The main role within the clinical studies officer is initially is more to do with recruiting care homes to be involved in any of the studies. Now, it looks quite simple if you think ENRICH has got a register of 400 care homes, but out of that 400 care homes, there's probably, if you're lucky, 20% that are involved in actively involved in research. So also an important part of any research is to get a good wide demographics, and it's not all, it's quite easy, I suppose, to get your city dwellers, your urban care homes that are happy to be involved, especially if they're within an area that's got academic support. But if you're trying to recruit to the more rural, within the more rural areas, that's quite tricky. But this particular study, I've got a lot of sympathies with it, because as I say, 25 years I was a community psychiatric nurse. For several years within that, I was also a pilot study as being a care manager for social work. And that's within the borders. So within the borders, we have, I was a community psychiatric nurse, so we had our own mental health data system. The general hospital had a separate mental health data system, so we struggled within that. Then when I became a care manager, I had to get access to the social work system. And then I set up some nurse-led clinics within GP practices who have a completely separate data system. So I can understand, the idea that Joe Public does think that all this data is shared, but it's far from it, and things don't seem to be, they've not improved in my lifetime. So I think this project is very important for Susie's point of view.
Thanks very much. And I suppose a question that I've been thinking as you were talking there as well, that is, I suppose, both for Susie and for Shona, in terms of residents consenting to having that data shared back with Datalock, and was there much kind of hesitation or resistance around this idea of data and our understanding of how that's shared? I'm not sure which of you would prefer to answer that question.
I'll go first, but I'm really interested to hear Shona's view as well. And I popped in the chat there a graphical summary that it came from our symposium that the Advanced Care Research Centre held not long ago, where I presented this work as well. And this group, More Than Minutes, have written a really nice, done a nice drawing which illustrates the fact, aren't you doing this already? And I think that comes through again and again when we ask this, that people do think that this happens already. So it is very frustrating from people's point of view to understand that doesn't happen. I did a little bit of going out to the care homes and talking to people before we did this project to try and hear what families and residents and staff thought about it. And there is varied views of people are generally think that people should know what they need to about them to provide their care, but there are some instances where that could be sensitive. And some of the things that was brought up in the care homes were things around when people move into a care home, they have to give quite a lot of detailed financial information to think about moving in and providing the support they need for their care. And people were justifiably concerned about whether that sort of information would be made freely available. So I think, but oftentimes people didn't have the opportunity to think about their information, what information was collected about them as part of their care, whether that could be used for other purposes, for research or for their care. Because I don't know that if people know that when you interact with the NHS, there's kind of an implicit, it's assumed, it's explicit effectively, that your data can be used anonymously by ethically approved researchers in appropriate ways to answer research questions. And you can opt out of that system, but most people understand that that's for the public good and they are happy with that. But in the social care setting and in care homes, we've not really had the discussion about what people think about the information that sits there. And when you have information collected about you in the social care space, what do you think about that? Are you happy for that information to be shared with appropriate constraints or not? And then if you lose the capacity to make those decisions for yourself, how do you let people know what you want for the future? So in the same way as when you move into a care home, when you have a plan about your health for the future, should we be having a plan about our data, our information? But I don't know how feasible that would be, Shona, when people move into a care home. You talk to them about loads of things, don't you? That would just be another thing to talk to people about.
Yeah, so we started first talking to our families and our residents about this about a year ago. I was looking back on my email trails, it was about a year ago. And at that point, I had quite different residents to what I have now. So I've just recently resent everything out to get more up-to-date consents and all the rest of it. And we have had some back, there are no problems at all. We are sending them to the power of attorneys of our residents because for the most part, our residents don't have capacity or they've got transient capacity. So if somebody's capacity comes up and down, we will have a chat with them. We'll see if they're okay with it, but we'll also have a chat with their power of attorneys. I do have somebody who doesn't want to be part of this, and it's just because it's mainly because it's new and how is it going to be used? And who's going to actually hold the data and the legal aspect of it, which is absolutely fair because it is very new and the discussion about who owns all the data has been extensive. I have stayed far away from that. I've let Susie deal with it. But for the residents, when they first come into a care home, we throw so much information at them. We ask for a lot of information from them. But this would be what one of the ways I've tried to explain it is, well, we only get your past medical history from what you've said. And if we're lucky, we'll get a summary report from the GP, which is bullet points at really is what it is. But if this was a bit further down the line, we would be able to actually have more information accessible without having to tell us everything that you've already told the social worker, the doctor, the hospital, and who else. It would just make things a lot smoother, and they're generally folk think it happens, so they're quite happy and they don't understand having to repeat and repeat. So getting consent hasn't really been a problem. It's just trying to make sure we're doing it as safely as we can for the residents who don't have complete capacity.
I think it's a really kind of salient point that people think, of course, this should have already been done. So it seems kind of an obvious thing to have in place that's not there. So I think it's really useful to know that that's kind of come from that. I have a couple of questions that were sent to us in advance, but also if anybody who's joined the call has any questions, feel free to unmute yourself, turn your cameras on if you'd like to ask questions. There's also the chat. But I'll ask one of the ones we have in advance, which is from David Richardson, who says, how can the pathways to data sharing be streamlined so that we can make effective use of our data?
Well, if we knew the answer, we wouldn't have to do this work. I mean, it's slightly facetious, but it's a really important question. I think access to data is really challenging and difficult, can be, and it's complicated. And I think the thing is, it means lots of different things to different people. So you have to be clear what you're asking for, why you need it, and where it comes from, and who's asking as well. So people who are asking for information, you can do a freedom of information request to ask for information from institutions about statistics that they hold. Or if you're a researcher asking a research question of a large data set, you can do that in a university trusted research environment. Or if you're a hospital manager trying to understand your patients, you can do that in the hospital trusted secure systems. So it depends on the information or the data you want to work with. And there are several organisations that work with the very large population size data, Public Health Scotland, Administrative Data Research UK, where they support the analysis and use of very large population level data sets, both at summary level and at individual level. And there's lots of research cohorts where you can ask specific questions. So I think that it is challenging for people to navigate that because there's so many possible different ways to do that. And I think health and social care also have slightly different pathways and they can be quite separate sometimes. So partly what I'm trying to do here is to bring is not to say that health is better, but it's more established. So how can we use some of the infrastructure, the lessons from the infrastructure that we have there to allow the access to the data, or to say that system didn't work in this circumstance, how can we do it differently? But I think the best advice I can give anybody who's looking to do data analysis is to speak to somebody who's done it before and get advice on how to do that, because that will make it more straightforward.
Thank you. And we've got a hand up, but I'm not sure the name of who the hand up is, I'm afraid. But if you're happy to unmute yourself, feel free to ask your question.
Hi, it's Janice Murray here. It's Janice and Jen. We're coming in from ACRC. Susie, I was looking at the dashboard, and if I'm right in thinking, you've got information coming in from the care home, and you've got information coming in from Datalock, and presumably maybe also information from GPs. How are you going to manage who's the most up to date, sort of the real time snapshot of the information?
Well, that's a great question. So when information is shared, it's really important to ask how up to date is it, because most of the information that we use for research purposes is often stored historical data and it isn't real time. So I think as researchers, we're quite used to using, okay, I'll look at the last 5 years of information because that's what I have, and consider that going forward. So Datalock has hospital information, has GP, and has some GP information, and is starting to bring in a little bit of social care information, things like packages of care that people have at home, and perhaps some payments that they have or telecare that they have in place. So there's a little bit of information that can bring that all together in Datalock in that trusted research environment, and then linking that into the social care data. From the social care side, so what we've asked Shona and our other partners to do is to provide us with an extract of that person's electronic record that's used in their care provision in the care home. Now, only probably about 30% of care homes in Scotland use electronic records at the moment, or that was what, when we last did a survey of that, which was probably a year or two ago, so maybe a bit higher now. But if your data is collected on paper, you clearly can't share your data electronically with Datalock. Shona, maybe you can say about the time frame of the data that you're providing and how easy it would be, whether that's a snapshot, and how easy it would be to do something that was more live.
Yeah, so the system we use, the staff put all the information in through a handset, and then it's uploaded just basically constantly. I can sit and have the feed going, so I can pull information from that as from today, however far back the person's been logged onto it. So since some of my residents have come in, we've got everything that they've ever done just about logged there. So we can pull that and send it on. But the thing with electronic ones is there's a lot of them. And a lot of different care homes use a lot of different systems, which is just an added I don't know what the word is, an added layer to try and figure out. But a lot of the information that I can pull can be pulled out onto a PDF, not a PDF, an Excel file, which can then just be, you can anonymize it and whatever else you need to do with it and send it on.
Complicated, right?
Yeah, it's complex, and because all the different systems. So maybe Bernie, you can say when you go to different care homes, you visit lots of care homes in different places. Do you know? I know that many of them use different electronic systems and paper systems, and so sharing data would be complicated from that point of view.
Yeah, I mean, it's when we're going into a care home, we're not, on the whole, we're not looking at residents' data, but it's one of the questions that we ask more and more now is what system you use, more for our own benefit, more to educate ourselves, and how, and also include how you communicate with relatives, carers. But the idea of having different systems, I suppose, is that was a situation that the health service was in 20 years ago. We were all using, each health board was tied into a different system and a different contract. So we're just playing, care homes are just playing catch up on where the health board was 20 years ago.
Sorry, can I just jump in there? What's interesting with the different care homes using different ones, it's because no one is recommended by our regulator, the care inspectorate. They can't do that. So it's up to us. And then that can be based on our finances because it's not funded. We have to pay for that. And what is actually available in our building. I'm an old Victorian building. I don't get Wi-Fi on the top floor. So I've got, my staff have to come down to make sure everything's getting logged and everything. So just now, there will be a massive variety, and a lot of people are just sticking with paper because that's what they've always done. We know that that's not a good reason, but it's so expensive to put these systems in place, but they are very good when they're used well. And there are some that are better than others, but that's a conversation for a different day.
Well, but I think it's really important, Shona, isn't it? And we've spoken with colleagues and also in England, because it was encouraged from a policy perspective in England with some backup funding to try, and some recommended providers, so that England now has, I think, about 80% of care homes are now electronic. So care homes that have a footprint in England and in Scotland will probably be starting to move to an electronic record, but without that system here, I think, as you say, Shona, it's really important to acknowledge that the impact of implementing something complicated like this on a care home, and the financial and the impact on the staff as well, to try and learn a new thing. And when you've got staff who move, if you've got your permanent staff, you can teach them one thing, but when you've got staff who may be moving between homes for bank reasons or filling in temporary shifts, that makes it complicated too. So I think we see the data, we see the information, and as researchers wanting to look at that, but I think you really have to understand where it comes from, who the person is that putting that information in, and what it really means. And I think that's part of this work, doing that in partnership with the care homes, was to say, okay, this might say that this person's weight is 207 kilos. Well, we all know that that's probably not correct, but why was that number put in? What were the issues that made that happen? And therefore, if it says something that looked sensible, is that as likely to be wrong as something that looks completely unreasonable?
Thank you. And I just want to check, Julia, did you have your hand up? I'll come to you then.
Thank you. Thank you for an excellent session. I have two questions, one for Susie and one for Bernie. Susie, you briefly mentioned the ethics and governance challenge, and I really wanted to ask, how did you navigate this process of negotiations and thinking about data management, ethics, and privacy? So I know it's a difficult question, but I would love to hear from you how you navigated that. And Bernie, you also mentioned about the challenges of involving rural communities. And this is something that I myself am based in Asher, and I also try to involve social care, care workers and care recipients. And I can see that is a challenge. And just, from anyone in the room, also Shona, you could answer this, but what do you think are some of the incentives that we could offer to get these populations involved, because indeed they're really underrepresented in research. Thank you.
Why don't you do that first, Bernie? Oh, you're still on mute. We keep trying to mute Bernie, but it never works.
Yes, the rural communities. By chance, I have just done a blog for a dementia researcher, the NIHR, on that very topic. I was a CPN in the borders at the same time as a clinical studies officer with NDN, so I would coordinate and recruit to mostly dementia studies. The big advantage was being a clinician. The participants were coming to me, and I would recruit them, and that's partly what we do within the NDN, with the permission to contact. We have a register called Permission to Contact, and we get people with dementia who will sign up, or any neuroprogressive condition, and that gives us a list that we can go to if we've got studies coming up, and it also allows us to screen through having access to their medical records. But a lot of it had, from our point of view, a lot of the recruitment within rural areas has got to do with relationships with the practices, and with the GPs, who are often one of the main gatekeepers. I wasn't involved in as much care home research back then. But look at the blog. Well,
I love the outsourcing to previous work by Bernie. That it does make it easier. I don't know if Shona, you wanted to come on that topic at all.
Do I? I don't know if I do.
That's absolutely fine.
I mean, I'm in the centre of Edinburgh, and I say yes to everything, much to my staff's delight. Let's go with delight. That's not what I mean, but yeah. So, like, yeah, you need a manager like me who just says yes. That'll be what I say. Yeah, let's go with that.
And then Susie, should we go to you for the ethics questions?
Well, I'll come to that in a second, but I think it's a really important learning point, not just for rural communities, but really for this work too, that it's all about relationships. That I don't like. I've only been able to do this work because, as Shona said, this work started a long time ago. We've known each other a long time through research and other environments of working together in the care home, sort of an innovation space, and it really has been through developing those trusted partnerships that we've been able to develop this project. And so I think people who develop a care home project think they can just parachute into a care home, do a project and come back out again. That's not how it works in that sector. It really is about fostering the relationships, spending the time understanding how the space works, building trust, and you have to take it slowly, and it can be frustrating sometimes because it feels like things take a long time, but I think that the outputs are much richer for that. You know, this project would have been completely different if I'd have just said, I'm going to take some data from a care home and see what it looks like, because, you know, it wouldn't have worked, and B, it wouldn't have been useful to the care homes, and, you know, C, we wouldn't have learned anything more widely from it. So I think, you know, my key learning from this project is it's all about the relationships, and that's a lesson for life, I guess. In terms of the ethics and governance, so we are doing an evaluation project around this, led by Eddie Donaghy, and supported by Nicola Crowe, who's one of our ACRC PhD students, to take the learning from this project, because I think it's really important that we share that from all the different perspectives of the stakeholders in the work. But certainly in terms of the ethics and governance, it's been a huge learning curve. I was really supported by Data Lock, and a big shout out to Pamela Linkstead, who's the information governance officer there, who had a big role to play in trying to navigate that. But doing any project for the first time is complex, and when you're treading new ground, people are always questioning what's the worst thing that could happen, because, you know, if you're sharing people's individual sensitive data, we're doing it currently for a small project within trusted partners, you know, this will be fine. But if we were to roll this out more broadly and start to build on this and build it to scale, then we have to think about the possible implications. And when you're sharing data about them, some of the most vulnerable, sensitive people in our society who have complex needs, and not also that the care homes are financial businesses and they have sensitivities around sharing information, because we know from COVID, when care homes were pitted against each other in terms of numbers without people understanding the context behind those numbers, it can be really negative. So, I've been really clear throughout this whole project that we don't just show the information without understanding the context that the care home sits in and explaining what that data really means. So it has taken a long time to go through the processes. We've very carefully built up the data sharing partnerships. We've had to really think about who are the data owners, the data custodians, who has the final sign off, where does the university and the NHS sit in that, what role do the care homes have. These are all private care homes that we're partners with, but what would that look like if they were health and social care partners? So another piece of the output from this will be we're going to develop a sort of roadmap about a pathway of how you bring data in to the trusted research environment in a more sustainable way. But I think we're not there yet. And I think that we do need to think about how systems work in the future if we move to more electronic care planning software in care homes and in our own lives everywhere. How do you feel about sharing that data? Do you want your information to be shared in the future? What does that look like? How do you give permission for that? And how does that follow you forward in the future?
Oh, thank you. I actually was thinking there when you were saying obviously about relationships and things, but Shona, you also said we need people like you who say yes to these projects. And I just wondered if you'd be happy to share a bit about kind of what makes you say yes and how we can kind of encourage other people in a similar position to yourself to say yes to research.
I don't know how to start. I say yes to everything because when I first became a manager about 4 years ago, I was clueless. I'd been a deputy manager at home. I'd managed a closure of a home, and then I got this job, and I didn't have a network around me other than the people I already knew who were happened to just be in research and things like that. So whenever I was asked to be part of something, I said yes, because it was another chance for me to make a connection and build a network around myself that would support me and be somebody I could go and ask questions of how do I do this? What do I do? Now I say yes because I've seen that it can change things and improve things slowly a lot of the time, but it gets there and people are starting to understand care homes better. That we are not just here to make loads of money and sit quite nicely and just minimal care to our residents. Absolutely not. We're here to really look after people to live until they die, and for them to have a good life and for them to have a good death. And the way that we can do that is by proving through research a lot of the time that we do these things for people, and we're not just here to sort of do the bare minimum. I don't think that answered the question particularly, but
no, I did really. I think it's really important. I think it's good for researchers to remember the perspective of why you might get involved, as well as that helps that initial conversation about why research might be important, but also why it's sometimes helpful when you already have those connections in research, because it's less of an intimidating idea in terms of being involved. We have a question that came in from Corinne that is open to the three of you. That's how could ongoing initiatives and organisations like the UKRN be of help? I am a local network lead for the UKRN and active in the Scottish Regional Network of UKRN members.
Yeah, I didn't really know about the UKRN before that question. I had a quick look at it before the meeting. So, but I think the sort of generic question to the answer to the question is the more the merrier. Like we need everyone to be involved to understand this question. We need people in society to understand that their information, their data is being collected all the time about them, and future research will take the data from your Facebook page, from your iPhone, from your Fitbit, from the number of times you click something on Google, put it together with your health record, the number of times you've gone to the GP, whether you bought paracetamol with your Tesco's card. I mean, there's so much information out there about you that I think we have to start thinking carefully about what we think about that, how we share it, how it's used, and what we want to do with that in the future. And I think the more people that are involved in that conversation from different perspectives, the better, because I think that's been the great thing about working in projects like this with people from different perspectives, and in the ACRC as well, the Advanced Care Research Centre, where we work across different disciplines, is that you see things from your perspective, but everyone has a different perspective, and it's so important to hear those and to understand those. So I think that we do need partners in this research. We need partners in all questions going forward. So I'm happy to link in with Corinne in the future, see what we can do. I think this is the first part of sharing the findings from. This is the first time we've shared the full team talking about these findings, and when we actually have the data, we're going to share that with the care homes first, obviously, and with the residents and the families. And then once we've done that, we really want to share the data more widely to understand what we do next. And that was why my slide there was, what are your ideas? How would you see us using this sort of thing? What lessons can we learn from this, so that when we build the next thing, it's not just from the ideas that I have of what I think is important, but it can be more general systems that will work, rather than having to build it again for every single project.
Thank you. So I'm just aware of the time, so I'm just going to put to the speakers, do you have any other things you would like to add or would like to say based on the conversation this afternoon? No, you're all happy? That's always a nice point to get to, isn't it? I think it's best to bring it all together there then, if that's okay with everyone, unless anyone has any final questions. I can't see any hands or anything, so I'm assuming everyone is happy. This recording will be, as I say, available on YouTube and on kind of platforms like Spotify, and you'll obviously be able to contact Susie and the ENRICH Scotland if you have any follow-up questions to this. And it won't be the only time you hear about this work. We'll be following this work going forward. But a massive thank you to Susie, Bernie and Shona for being part of our first In Conversations With, and for all of you for joining. We really appreciate it and hope you find this useful and helpful. But other than that, I hope you all have a lovely afternoon.
Thank you. Bye.
Thank you so much, everyone.
Thanks, Remy.